Hello, this is Dr. Bobek, uh, ex-professor of pediatrics and division of endocrinology, and also retired colonel from US Air Force. Continuing with the series of interesting case presentation, today I'm going to present two very important and interesting cases as well. Now this will be a very good materials to learn for endocrinologists, pediatric endocrine fellows, as well as general pediatrician who actually referred this patient to me. So this was a family and two patients, their first cousin was referred to me for not growing well. And incidentally, one of the patients also had frequent low blood sugar, and the pediatrician was concerned because the growth velocity, because of the growth velocity which has decreased significantly, and this family was going to a pediatrician and they are not very happy with the care, so they just transferred to this pediatrician, and I'm glad they did that because this has been ignored for a long time. Incidentally, these both patient has gingival hyperplasia or growth, and for that they have been followed by a surgeon, a dental gum specialist. And gingival fibromatosis, just let's go back a little bit about the introduction. Gingival fibromatosis is a slow, progressive benign enlargement of the gingival tissue, and this is associated with also delayed dentition, and as a result of that, the teeth is buried under the gum and they look very small, and this is because of the hyperplastic gum and significant cosmetic problem as well as functional problem because of the size of the teeth. And they have to go to dentist a lot. So gingival fibromatosis could be isolated, or it could be hereditary gingival fibromatosis, and the incident varies from 1 in 175 to 750,000. And most of them are autosomal dominant, but there are also autosomal recessive variants. Condition also associated, many of these conditions also associated with hypertrichosis, mental retardation, seizure disorder, as well as hearing loss. And the locus of this chromosome has been on 2p21. So in addition to that hereditary gingival fibromatosis, one need to worry about certain drugs that may have caused hypertrophy of the gum, and they are like dilantin, nifedipine, valproate, cyclosporin, and phenobarbital. And there are many other drugs. But it could be just plain isolated fibromatosis. It could be part of the syndrome or even poor dental hygiene, but it just could be, no cause could be found. So our patient one is 8 years, 9 months old, African American female. Can present it with recurrent hypoglycemia and growth retardation, because this is how this patient was referred to us, had previous history of hospitalization because of the frequent low blood sugar, and the reviewing of the growth chart pediatrician, I saw there is a declining in growth velocity over the period of last 4 or 5 years. Was diagnosed with, as I said, gingival fibromatosis and followed by the gum surgeon, orofacial and gum surgeon. And when the gum hyperplasia is out of control, they really have to go to the dentist or gum specialist to get the surgery. This patient, the one that I am discussing now, also is developmentally delayed and have speech problem. And the other cousin, who is 13 years of age, was referred to me. The 19 years of age, there is another cousin who is not living with them, and mother said that he also had very similar problem, and he is not very tall. But that one did not come for evaluation. The physical examination shows the first pattern is 114 centimeter, which is minus 2.5 standard deviation, and the weight is at 25th percentile, and has some dysmorphic features, but clearly gingival hypertrophy is very prominent, and there is a picture that I will show you later. And there is a mid-facial hyperplasia, mild proptosis, and has high arched palate and hypertrichosis. She has no sign of puberty, otherwise rest of the physical examination was completely normal. And this is the one I'm going to show you. This is gingival hypertrophy. Actually, this patient has surgery about 3 months ago, so this is, mother said that this is much better, but clearly one can see that there is gingival hypertrophy. And is the other patient too that I'll come back is also pretty similar. So let's go to the patient number 2, which is also the first cousin. It's a 13 years old African American male and was also referred for short stature, but he particularly did not have any history of hypoglycemia, although he is short in stature, but also have little dysmorphic features. And just like his sister, was also diagnosed with gingival fibromatosis, which was thought on the basis of hereditary. He is underweight and several gingivectomy. Also got lots of operation done, and he is also mildly mentally retarded with some speech problem, but not like his sister. And as I have said, that there is 19 years old brother who had delayed puberty and has hereditary gingival fibromatosis, was short in stature and was not there, and we wanted to bring him back for evaluation, but the family did not agree. The patient 2 was 134 centimeter, again much less than minus 2.5 standard deviation, and the weight is on 35th percentile, and he did have somewhat narrow mandible, misaligned, very wide spread teeth, and his gingival hypertrophy, according to Bob, is not as bad. He required surgery less often than his sister. He also has higher pallid and mild proptosis. His testicular volume is a prepubertal less than 4 ml, and he have had no sign of puberty, no pubic hair. Very similar picture. So the most common and the fundamental case related laboratory evaluation shows that they have, both of them have completely normal metabolic panel, which did include the liver function, kidney function, CBC, etc. Thyroid function test and serum prolactin, both of was done, and both of them are within reference range, normal range. Karyotype was done, and both of them has appropriate, sex appropriate karyotype. The sister is 46XX, and the second patient, the brother, is 46XY. We also did a head MRI. Both of them was looking in the pituitary hypothalamic area, especially. Both of them were unremarkable. The first one patient's bone age was 7 years, which is delayed by 1 year and 9 months. 1 year and 9 months, and the patient 2 is 10 years old and delayed by about more than 3 years. So some of the basic evaluation, some of the endocrine evaluation that we got here is the patient 1 has low IGF-1 33, the patient 2 is also low 50, IGF-BP3 was low in both cases. Growth hormone was baseline growth hormone was 3.8. At the same time, the blood sugar was 34, and this is the patient 1. As 60 minutes after clonidine went only up to 2.4, actually was less. And patient 2 has both clonidine and L-Dopa. The highest response we got 4.9 and 3.2. So 3.2 was after 60 minutes of clonidine, and 75 minutes post L-Dopa was 4.9. Insulin level was 3 MIU per ml when the blood sugar was 34. So it's within reference range, but there is no hyperinsulinism. And cortisol level when the blood glucose was 34, and this sample was drawn when we were doing the growth hormone stimulation test, was 7.7. The response is inadequate. The patient 2 had a normal blood sugar, and the response was 11. We measured ACTH level, which was 21 with the blood glucose of 34. And so ACTH level is within the reference range but is low. So cortisol response, we did the post ACTH with 0.25 milligram of ACTH, and as you can see that the cortisol response with the patient 1 was maximum 20.3 at 90 minutes. But the response to note that it was kind of sluggish. And her brother was pretty good. In the 60 minutes was 23.8. So although he did make a normal number, but that took about 90 minutes, we should have been in 60 minutes or so. So there is a delayed response. So the patient 1 was started on growth hormone, and we also started her on hydrocortisone, 5 milligram in the morning and 2.5 at night. And that's seen in about 3 months. Amazingly, there was no more hypoglycemia. In the morning, they used to, actually the family used to measure blood sugar because of the frequent hypoglycemia. The pediatrician gave them the blood sugar machine and they knew how to measure it, but no more hypoglycemia. So let me summarize the growth rate as a whole over the period of 3 years that she was on growth hormone. Growth rate was 9 centimeters in the first year, which is pretty good, 8.2 centimeters in the second year, and 7 centimeters at the end of the third year. But the problem was, although there was a good response with growth hormone, but there is a progressive gingival hypertrophy, which is growth is much faster than when she was not on growth hormone. So therefore the patient and the parents, I mean the mother, did not want to continue growth hormone, and the dental surgeon also said that the kind of aggressive hypertrophy is because of the growth hormone. So at least we could continue with the growth hormone for 3 years, and she had to have a lot of operation on the gum. So after 3 years, this continued, and again in 11 years of age, around 11, the pubertal development noted with breast development and some pubic hair, suggesting that there was no problem with puberty. The patient too also started on growth hormone and he did grow 8.5 centimeter in a year, and growth hormone was discontinued after 13 months by the family because of the same gingival hypertrophy problem. And again, 13 months after growth hormone, he started having pubertal development. Testicular volume was 8 ml and some few pubic hair. 8 ml is stage 2, so early pubic hair. The hereditary gingival fibromatosis may be associated with rare syndrome, and endocrine problems are rarely reported. And there is no publication about the final height of any of the patients who had hereditary gingival fibromatosis They did not need growth hormone, but there is no final height. So whether they are short in stature is difficult to know. And the cause of the growth hormone deficiency is remain unclear, but it could be central, maybe growth hormone releasing hormone insufficiency, but these are all speculation. So since there was no such report, by the literature review, I find out a very interesting paper that was published in British Orofacial Surgery Journal, and this was a study from Finland by Dr. Okarinen and his colleague. And he reported 8 children in a family with fibromatosis, 5 females and 3 males, and 5 children were short in stature and they have delayed bone as well as dental age. So 5 children were short in stature. That's the only credible report of short stature in the children. And all 5 had growth hormone deficiency, and he speculated that just like it could be it could be central or hypothalamic lack of growth hormone releasing hormone. Only one of the youngest girl, who was 8.5 years of age, was treated with growth hormone and with very good response. But in that article, I could not find a problem with significant gingival hypertrophy on growth hormone. Two sisters also found to have gonadotropin deficiency because they went puberty. They did not go through puberty, and one patient had very delayed puberty, and another patient did not go through puberty. But I do not have. He did not put any follow-up data that whether anything was done because of that. And we really did not have any other article anywhere this condition associated with endocrinopathy. So again, this patient in this report were first cousin, and all family members have gingival fibromatosis and no short in stature. Whether all those were short in stature, but they are all kind of grown up, and so there was no chance of doing any other evaluation on any of them. Again, I believe that this still possibly central growth hormone deficiency could be growth hormone releasing hormone deficiency. This patient had a high arch palate and also some dysmorphic features, midline hypoplasia. So this all consistent with central growth hormone deficiency, and which most likely is in a hypothalamic level. And the other genetic form needed to be considered, but we did not find any. Our patient 1 had also low cortisol or delayed response to the cortisol. They may have been the cause of growth hormone, hypoglycemia, and ACTH response was also delayed. It could be just like growth hormone releasing hormone deficiency with corticotropin releasing hormone deficiency. A possibility is there, and I think that most likely was the cause. Both patients had showed pretty good response with the growth hormone therapy, but because of gingival hypertrophy, we had to stop the growth hormone. and puberty was observed in both patients. Now we have some data of growth. When we stop the growth hormone, the growth rate declined to 3.8 centimeter in the first year and 4.2 centimeter for his brother, for her brother, but no hypoglycemia. So in conclusion, the growth hormone deficiency is probably more common in a patient with hereditary gingival fibromatosis, and this entity should be, a patient with this entity should be evaluated, and especially if they are short in stature, for growth hormone deficiency. And growth velocity should be monitored. See, this is not very well known to the pediatrician. Another problem, hormone problem, mostly maybe central, like cortisol gonadotropin deficiency. The deficiency could be also partial, should be considered. So this case actually bring about the hidden cause or any hormone deficiency that they may have. As I said, the most of the patients are autosomal dominant and some are recessive, and they pay more attention to the gingival hypertrophy, and the pediatrician should monitor the growth velocity significant, growth velocity yearly at least, and if there is any suggestion of declining in growth velocity, they should be referred. And since this is not very well known, so a lot of people probably miss this diagnosis, and many a time it could be just partial growth hormone deficiency or partial gonadotropin deficiency. So they just get by, and sometimes the delayed puberty may be noted, and which could be also related to the partial deficiency. Now, as I said that I bring about these two cases, which was also published in Endocrine Practice Journal with my colleague, to alert the pediatrician and even the dentist that those who see the patient with hereditary gingival fibromatosis should be aware of the other hormone problem. Unfortunately, we could not evaluate the 19 years old, but he was 19. That's what the pressure was not there that much, and as I like to say that this group of patients probably there and not being evaluated because we probably don't know about them because they are not the priority. Gingival fibromatosis was the priority in this patient, but this pediatrician was smart enough, and I might compliment, that pay attention to the growth chart, which has been, the growth velocity decline was already there for a long time, and the hypoglycemia, and he put these two together and thought about this possibility and referred the patient. Okay, so again, I like to thank you all for following my YouTube channel, and there will be very soon a very interesting case report also. Until that time, good luck and have a good day. Thank you.